Thank you, Liba. Hi, everybody. Welcome to Pediatric Grand Rounds. I want to begin with our land acknowledgement. We would like to acknowledge the Ramaytu Shaloni people who are the traditional custodians of this land. We pay our respects to the Ramaytu Shaloni elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We're proud to continue the tradition of coming together and growing as a community. We thank the Ramaytu Shaloni community for their stewardship and support. We look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And it's my pleasure today to introduce our speaker, Dr. Patrika Tsai, who is a pediatric gastroenterologist here in our department. She's been on the faculty since 2007. She's board certified by the American Board of Physician Nutrition Specialists and the American Board of Obesity Medicine. She directs the Pediatric Obesity Clinic here at UCSF. She's originally from Chattanooga, Tennessee, and she completed her undergraduate studies at Harvard and then a medical degree at the University of Tennessee, and then did her pediatric residency at Emory, and then a fellowship at Harvard in pediatric gastroenterology and hepatology and nutrition. She also earned a master's degree in public health from Harvard. And Dr. Tsai's interest, in addition to pediatric gastroenterology, also includes celiac disease and childhood obesity. With 1 in 3 children and adolescents affected by overweight and obesity, she believes that this is one of the most important health challenges facing our nation's youth, and I think she's completely right about that. And so with that, I'd like to welcome Dr. Tsai to give our grand rounds today. Dr. Tsai, welcome.
All right. Can everybody hear me okay? Okay. Thank you so much, Dr. Hirsch, for that introduction. And then thank you also to the organizers for giving me this opportunity to talk to you all today about pediatric obesity and also about the exciting treatments that we have available these days. So starting with some housekeeping, I don't have any financial disclosures, but I will be discussing off-label use of medication, and I will mention brand names when relevant, but I do not endorse any particular brand. So our goal over this next hour is to review current pediatric obesity guidelines, as well as to outline any pharmacotherapy options and identify considerations for bariatric surgery. So we'll start off with some definitions. Overweight is defined as having a BMI that is greater than or equal to the 85th to the 95th percentile. In adults, this would correspond to about 18 to 25 for the BMI. For obesity, that would be anything greater than or equal to the 95th percentile, and so greater than 30 in the adult population. And then for severe obesity, this is actually broken down further now. And so in pediatrics, we would say people have class 2 obesity if they are greater than or equal to the 120th percentile of 95th, or greater than or equal to 35 kilograms per meter squared. And then for class 3, that's if it's greater than or equal to the 140th percentile of 95th, or greater than or equal to 40 kilograms per meter squared. Just to give a little bit of background on this, about 20% of children who are between the ages of 2 and 19 are obese. And so that's affecting around 15 million children and adolescents. Now, about a quarter of Hispanic children and Black children are affected. And I also have some percentages here on the right with the adult population, just to give you some perspective. And then looking in the white population, it's about 16%. And then in Asians, it's around 10%. Now, one thing that we should note is that obesity did increase during the pandemic. As you're aware, kids had to go to remote learning. There were fewer opportunities for being outside and having activity planned with sports and things like that, which shut down for a lot of families. Now, if we think about it, 1 in 5 children are obese, but 1 in 3 are either overweight or obese. And so that's a huge percentage of our pediatric population. The other thing to consider is that most of these kids are probably going to be overweight or obese also as adults. And studies have shown that at least 80% continue with this problem as adults. So this is taking a look at some maps, and this is going back to 2011. And this is just a sense of what the self-reported obesity is among the adult population. So as you can see here, as you get more orange or red, the number of people who report that they are obese increases. And so what you see is that kind of in the Midwest, the southern states and some on the East Coast, it's about 30 to 35% with that light orange color. Now let's fast forward about 5 years to 2016. And what you see is that there's a new color that comes up. And so now these darker orange colors represent 35 to 40% of adults that are reporting that they are obese. So fast forward 5 more years and we have more colors. And so now we're going up to 40 to 45%. And so this has just been increasing, every year, unfortunately. And what you see is that, there used to be green on the map. There's only one holdout with green now, and that's in DC. The greens disappeared everywhere else. So what else is going on? With obesity, we see that there are many complications and that these affect multiple organ systems. So we see problems with diabetes. We also see problems with NAFLD, which has been renamed. So as an update, this is now called MASLD. And so that stands for Metabolic Dysfunction Associated Steatotic Liver Disease. Still the mouthful. We also see problems with cholelithiasis and cardiovascular disease, dyslipidemia, hypertension. We see things affecting our kids with OSA or obstructive sleep apnea. There can also be many orthopedic issues, joint pains, knee, hip issues. There can be problems with pseudotumor cerebri, which is also now idiopathic intracranial hypertension. We see problems also not just from a physical perspective, but from a mental health issue too. So we certainly see many adolescents who are suffering from depression, body image disorders, or eating disorders, such as binge eating or bulimia. And then also there's a lot of social isolation. I will have to say that, I referred during the first year pandemic more kids from our weight management clinic over to the adolescent medicine clinic for eating disorder in that 1 year compared to the 15 years that I had been practicing before. Definitely we see, body image and eating disorders as a problem too. So, we've talked about, the scope of the problem and the complications. So what exactly can we do about that? And that's where I think we should dive into the AAP guidelines. So just to give a little background and history on this is the first set of clinical practice guidelines by the AAP on obesity. And this was released last year in January. And this, the last time that the AAP really commented on it was back in 2007 with the AAP expert committee recommendations that were published at that time. And then there's also the AAP Institute of Healthy Childhood Weight Algorithm for the assessment and management of childhood obesity that came out in 2016. With regard to the guidelines, what we know is that obesity has often been framed as a matter of personal responsibility. So it's, maybe we're not exercising enough. We're just not eating the right things. But we know that this is actually very multifactorial. There are so many issues that come into play, such as environment, socioeconomic status, genetics, epigenetics, many different issues. And so, just to blame it on personal responsibility really oversimplifies the problem. So one thing that is nice about the guidelines is that the lifestyle interventions are still very basic tenets. And so these would include, watching for healthy nutrition, as well as making sure that we're encouraging physical activity. However, the guidelines are really great in moving from a watchful waiting stance, of seeing whether the kids grow out of obesity, to a much more aggressive one that recommends trying to treat, much earlier. So the guidelines do recommend now starting or considering pharmacotherapy or bariatric surgery as appropriate. Now, of course, there's a lot of controversy that came out when the guidelines were published because there were concerns about increasing the risk of eating disorders and the use of medications and bariatric surgery at much earlier ages than in previous iterations. So the topics included are quite broad, and the guidelines are very long. They're about 100 pages if anyone's had a chance to peruse them. So the things that they go over include things like health equity, racism. It goes over bias and stigma, which I think is really important because it's still, a very difficult topic for families to discuss, and then for us as a society too, because there's certainly a lot of body shaming that happens in social media and in the press. The guidelines go over adverse childhood experiences and epidemiology, as well as risk factors. And then they move on into evaluation. It goes over comorbidities, treatment. And then what's also good is that it goes over systems of care, as well as different barriers that our families face. So what I wanted to do is to just go over the 13 key action statements and just distill it down, since I think that's really the take-home message from the guidelines. And so we'll go over those in the next couple of slides. First, we need to have an assessment of BMI percentiles annually in all of our kids that come to clinic. And we should evaluate, overweight and obesity for these children with a good history, mental and behavioral health screening, social determinants of health, evaluations, a physical exam, and then appropriate testing. For those that are 10 and up with overweight, we can check for abnormal glucose metabolism and liver function with risk factors for type 2 diabetes or NAFLD or MASLD. For those that are 2 to 9 years of age with obesity, we can also evaluate for lipid abnormalities. So children and adolescents should also be treated for overweight and obesity at the same time as they're being treated for their other comorbidities. I think it's now more appropriate for us to make sure that we're addressing those comorbidities rather than just waiting to see, oh, let's get the weight under control and then we'll take care of it, because the weight, may not become under control for several years. And so in the meantime, these comorbidities are continuing to worsen. Next, we should also evaluate dyslipidemia with a fasting lipid panel. And then for those who have prediabetes or diabetes, we can check with a fasting glucose or OGTT or hemoglobin A1C. To check for MASLD or NAFLD, we can use an ALT. And we should also check for hypertension with a blood pressure at our visits starting at 3 if overweight or obese. And we should always treat our overweight and obese children with principles of having a medical home and having a chronic care mindset that's family-centered and non-stigmatizing, acknowledging that there are several different drivers for obesity, including biologic, social, and structural ones. We should try to use motivational interviewing to be able to engage our patients in this discussion and help our families in treating overweight and obesity, because sometimes, families, there may be some denial or there may be acceptance, but then there are challenges in terms of trying to make behavioral changes. And we should also try to provide or refer for intensive behavior, life, and lifestyle treatment, which we believe is more effective with more contact hours. Ideally, we'd like around 26 hours over 3 to 12 months, if possible. That averages to be somewhere around, 2 hours a month if we go on the slow end of things. And then here's where there's been a lot of controversy, and that's, 10 and 12 and 13. And number 12 is to offer weight loss pharmacotherapy to those who are 12 and up with obesity, and then to offer referral for bariatric surgery for those who are 13 and up that have severe obesity. And then the U.S. Preventive Task Force is also currently doing an update to their recommendations as well. And they're, pretty much at this point aligned with the AAP guidelines, saying that we should refer, especially for those who are 6 and up, to make sure that they have comprehensive treatment and intervention if they have a BMI greater than or equal to the 95th percentile. And they also recognize that there are a lot of challenges that the families face in trying to seek this type of care. So moving into some of our treatment options, I want to talk about the different medications that we have available. And so I have about 10 or so that I'm going to review. And I think that, depending on, comfort of, pediatricians in the office, these are things that could be started in a Gen Peds office. So I will be very clear about which medications are off-label and which are not. And so the first one that we'll talk about is metformin. So this one is a medicine that is considered off-label, and it's FDA approved for children who are 10 or greater than 10 for type 2 diabetes. And this works by inhibiting gluconeogenesis in the liver, and it enhances insulin-mediated glucose consumption in peripheral tissues like the muscle and the liver. Now, why it has its mechanism for weight loss effects is a little bit of a gray area. Some thoughts are that there are some GI side effects, including diarrhea, and then also some stomach aches, which might affect appetite. The dosing here is going to be 500 to 2,000 milligrams divided twice daily. And the side effects I mentioned already include diarrhea. There can also be some gas. There could be some concerns for lactic acidosis. It can also lower some B12 levels as well. The next one would be lisdexamfetamine. And so this one is off-label. And this is FDA approved for those who are 6 and up for ADHD, and then also for binge eating disorder in adults. Now, this is a stimulant. And so it's the prodrug for dextroamphetamine. And this decreases dopamine and noradrenaline reuptake in the nucleus accumbens and decreases the hedonic reward-based eating behaviors. So there are going to be the side effects that we would expect from stimulants. And so those would be an increase in blood pressure and heart rate, and then any worsening of psychiatric behavior. So contraindications for this would be things like cardiac abnormalities, because sudden death has been reported. Orlistat is one that actually is FDA approved for those who are 12 and up. So this is on label as an indication. This one inhibits pancreatic and gastric lipase and decreases lipid absorption. So the dose here is going to be 120 milligrams 3 times a day with meals. The side effects are that it does cause oily stools and diarrhea. There can be some abdominal pain, some gas, some fecal urgency, and then it can potentially cause some fat-soluble vitamin deficiencies. So contraindications for this would be chronic malabsorption, cholestasis, pregnancy, and recommendation would be to take a multivitamin that has fat-soluble vitamins in it. Now, what's interesting is that this is actually available over the counter at half the dose, 60 milligrams. And this is for those who are 18 and up. And that's 1 capsule with meals no more than 3 times a day. And let me just add one more thing. This was approved in 1999. And in just for marketing, it's been marketed as Ollie over the counter. And the weight loss here is about 5 to 10 pounds. And it's about $80 for 120 capsules. Topiramate is considered off-label. This one is FDA approved for epilepsy for those who are 2 and up, and also for migraine prophylaxis for 12 and up. This one blocks neuronal sodium channels, antagonizes glutamate receptors, inhibits carbonic anhydrase, and we think it suppresses appetite by augmenting GABA activity. The dose here will be about 25 to 100 milligrams daily. I usually just start at a low dose. And the side effects here are reversible cognitive dysfunction, so brain fog, which is a concern for our teenagers, right, for school. And there can be some metabolic acidosis. There's also risk for kidney stones, and then some tingling or paresthesias. This one can result in about 10 pounds of weight loss, and it's about $12 to $40 per month. It is a known teratogen, though, so we do need to counsel our teens, particularly about the fact that it could decrease the efficacy of birth control pills. And so they may need to have some other methods of contraception. And it may be that they need some serial pregnancy testing. For anyone who has a risk of seizures, then if we're weaning the topiramate for whatever reason, we do have to be careful about bringing up the seizures again. And we do need to monitor creatinine bicarb as well. Phentermine is a very old medication. This one's been approved in 1959. It is a controlled substance. It's a stimulant. And this one can result in about 3% of weight loss at 3 months, or 5 to 7% at 6 months. So if you're starting at about 200 pounds, you might lose around 10 to 14 pounds. And this one is relatively cheap. It's about $10 to $50 per month. And it's been FDA approved for those who are 16 who are older than 16 for up to 12 weeks. Now, do people stop it after 12 weeks? Many actually do continue because obesity, as we know, is a chronic condition. And so it doesn't stop after 12 weeks. And so many do end up continuing. So this reduces the reuptake of norepinephrine stimulating melanocortin hypothalamic neurons. And it affects serotonin and dopamine reuptake, inhibiting appetite. And the doses here may be from 15, 30, or 37.5 milligrams once a day. The side effects here are going to be what you might expect with stimulants. So it could be some irritability. There can be problems with insomnia. So we want to take this earlier in the day. There can be some mood changes and dizziness, tremor. You have a dry mouth. And then there can be heart rate and blood pressure elevations, as well as some GI issues. Unfortunately, with almost all of our medications that we can use for weight loss, they're all going to have some type of GI side effect. And then contraindications would be any concerns for past or uncontrolled cardiovascular disease, hyperthyroidism, glaucoma, and then use of MAO inhibitors. Now, what's a good medication that's also come out lately is phentermine and topiramate together. And so this has been marketed as Qsymia. And Qsymia was approved in June of 2022 for adolescent weight loss, but it was approved back in 2012 for adults. This one can result in about 30 pounds of weight loss. And the cost, though, is definitely more expensive. So it's about $150 to $300 per month compared to the phentermine or the topiramate, which sometimes we can prescribe separately if insurance is refusing to cover the Qsymia. And this one has been helpful as well. So the side effects are going to be similar to each of the components on their own. And the way that this one works, you start it at a very low dose for weeks 1 and 2. And then if tolerated, then you move up into the next dose and you can maintain that dose for weeks 3 to 12. If we're not seeing good weight loss with that, so 3% weight loss or a 3% BMI decrease, then we can escalate the dose again for a period of about 2 weeks and then move on into the full strength dose, which is at 15 and 92. So now we move on into what are really exciting medications. So these are the injectables. These are GLP-1 agonists. And so liraglutide was FDA approved for those who are 12 and up that have a weight of 132 pounds or 60 kilos, as well as meet criteria for obesity. This was also approved for type 2 diabetes much earlier. And so in the past, it had been approved as Victoza. And so that was approved in 2010 for adults with diabetes, and then for 10 and up with diabetes in 2019. So, even though these medications have just been more recently approved for adolescents, we do have experience using them in the adult population. So with liraglutide, it's interesting, the dosing for diabetes management actually tops out at a lower dose than the max dosing for weight management. And so it stops at 1.8 for the diabetes indications, but then we can go up to 3 milligrams when we use it for weight management. The dose escalation starts at 0.6 and goes by 0.6 each week. And this is given daily. You go up to a max of 3 milligrams a day. And so one thing to keep in mind is that if you're using this medication, you do need to also order the needles and the sharps container and some alcohol wipes, because I think sometimes some families forget that they may need to take care of it. And there are videos that are on the websites which are very clear in terms of how to use the medication, and those have been very helpful as a reference for the families to be able to use. So as far as the side effects for liraglutide, this can cause fatigue. There can also be issues with headache and dizziness. I think that the biggest one that we see, and that you've probably read about in the press too, are that there are a lot of GI side effects. And so there can be a lot of nausea, reflux, vomiting. There can be stomach pain. The other thing that I really worry about with this is that there is an increased risk of depression and mood changes, and there's increased risk for suicidal ideation. I've definitely had patients who have noticed that they were not able to tolerate the medication because of the emotional side effects that were occurring. It can also cause a higher risk of pancreatitis. And so, that is a very real possibility. You can have some issues with increased heart rate as well, and hypoglycemia. And there's some other things, including, injection site reactions. I won't list or go over all the side effects. Contraindications are going to be multiple endocrine neoplasia syndrome, type 2, or family history of thyroid cancer. There are some rodent models that suggest that there is increased risk for thyroid cancers. Average weight loss for this is going to be around 21 pounds or so. It is fairly pricey. It's going to be about anywhere from $1,000 to $1,500 per month for the medication. And the slide just shows how it's performed in the studies. And I think the main thing to see on this is that if you look here, if you look here, what you can see, this is placebo, and then here is with the liraglutide. This was about a 1-year study, so the medication was given for it's about 56 weeks. And what you can see is definitely there is a drop in weight and BMI at the end of the 56 weeks. The problem is that once you stop the medication, this is the follow-up period afterwards, you can see that the weight does go back up again. But you can tell that it's not as high as it was in the placebo group. And then if you think about obesity as being a chronic condition and cumulative exposure over time, I think there's still some role for using the medication, even if families decide that they want to stop, because there is less injury and inflammation happening to the body during that period of time that they are on the medications. So moving into semaglutide, this one is really exciting because this one is once a week. So for obvious reason, it's much more popular than the liraglutide. The liraglutide is marketed as Saxenda. The semaglutide is marketed as Wegovy. And so the Wegovy is what many of us have heard in the lay press. Ozempic is the same medication, but it's the one that's indicated for diabetes. This is approved also for kids who are 12 and up and have a BMI greater than 95th percentile. So this one comes in an oral form and an injectable form. The oral form is not approved for a weight loss indication. It's for diabetes. It is long acting because there's decreased degradation by DPP4. And this one is, it comes in a pen that's already pre-filled. So then the families don't have to switch out the needles, which makes it more convenient for them. And you start with a box of pens, and it has 4 pens in it. And each week you use one new pen. Each month, then you escalate on the dose to the next one. So it starts at 0.25 and then goes up to 0.5, 1.7, and 2.4. And 2.4 is the max dose. Side effects do increase as we go up, and the side effects are similar to the liraglutide. So these are just some graphs also showing that there was a significant decrease in weight and BMI after a little over a year with the medication. And then coming off the medication, you also see that there were weight and BMI increase as well. One medication that has just recently been approved that I'll mention is something that's called tirzepatide. That one is approved for 18 and up. And so, not as accessible for us in the pediatric realm, but I just want to mention that. That one is being sold as Mounjaro for diabetes indication, but it just got approved for weight loss and it's being marketed as Zepbound. And so Zepbound has been priced to be at about $1,000, so just a little bit cheaper than the other one. And that one I know is more accessible now. So my hope is that with Zepbound being accessible to the adults, that hopefully those patients who are eligible for that will switch over to those medications. So then that may alleviate some of the shortages that we're seeing in Wegovy and Saxenda, and have a trickle down effect, so that we're able to prescribe and to get these medications out to our patients. The shortages have been really challenging, and what's happened is the company has cut down on the starting doses of Wegovy in order to be able to meet the demand of the people who are on the higher doses and to be able to maintain them on the higher doses. So they're limiting the number of people who can start the medication. I do also want to just go over the SELECT trial, which just came out in December. And this is a study that is important, I think, because it shows that there are actually important outcomes with regard to improving health in our patients who are on these medications. And so this was published in the New England Journal of Medicine in December. And they did a study with 17,000 patients who are greater than 45 or equal to 45 and had a BMI of 27 at least, with no history of diabetes. And so these patients were randomized to either placebo or semaglutide. And what they noted is that 16% discontinued because of adverse effects. And so these medications are great, but they're clearly not for everyone because not everyone can tolerate them. And they followed these patients for 34 months, give or take 13 months, and then that was the exposure to the medication. And then the follow-up period was about 40 months, give or take about 9 months. And what they looked at was a primary cardiovascular endpoint, and those endpoints were death from cardiovascular causes, a non-fatal MI, or a non-fatal stroke. They found that this occurred in about 6.5% of the patients who were on semaglutide, but then it was higher at 8% in those who were on placebo, with a significant, statistically significant p-value. So we are seeing that there are definite outcomes in terms of avoiding these severe cardiovascular events in people who are being treated with these medications. So we're hopeful that this, convinces our insurance companies that these are medications that can be life-saving. I will just briefly mention setmelanotide in respect for time. This one is really just for some of our genetic mutation-related obesity syndromes. And so I would not expect these to be given in a general pediatrics office. These, I think, would be seen in a tertiary care center. And then naltrexone bupropion is one that's marketed as Contrave. This one can result in about 5 to 15% weight loss. This one is for adults, and so I won't spend as much time talking about that. This slide, I just want to show just a little bit of a comparison on some of the medications that we have and how they affect the Z-scores for the BMI. And what you can see is that the liraglutide is really one of the most effective ones, so one of the GLP-1 agonists. And then we know that semaglutide is actually even more effective than the liraglutide. And just in comparison, topiramate and phentermine on their own, they seem like they're lower down, but actually the two together are synergistic, and so it does raise them up higher. Metformin is going to be limited in how much, that may be about 5 to 10 pounds, and then the orlistat also is limited to a few pounds too. And insurance authorization may be required for many of these medications. All right, I want to switch gears now and focus on bariatric surgery. And the indications for bariatric surgery at this point are if you have a BMI of greater than or equal to 120th percentile or 35 with a comorbidity. And then the other would be for class 3 obesity, so BMI of 40 and up or greater than or equal to 140th percentile. So what are the comorbidities that we're looking at? Anyone that has OSA, type 2 diabetes, idiopathic intracranial hypertension, Maslow's disease, SCFE, reflux, and hypertension. With regard to complications, we would recommend avoiding surgery in those who have anything that would be medically correctable as a cause of obesity. If there are any issues with substance abuse problems within the preceding year, this may not be an appropriate time to pursue bariatric surgery. Another consideration is that families where there may be issues, whether it be medical, psychiatric, psychosocial, or cognitive, any of these conditions that might prevent adhering to the post-op dietary and medication regimens or impairs decision-making capacity, that can be a contraindication. Any plans for pregnancy are a definite contraindication. You really want to avoid pregnancy for at least the first 18 months. 2 years would be better. There are concerns about the micronutrient deficiencies that might occur, and so those could potentially affect the fetus. And then if there's any inability of the patient or caregivers to comprehend the risk and benefits of the weight loss procedure, we would also want to proceed with caution. At this point, there's really one procedure that we would recommend in the adolescent population. So a while back, we used to have the gastric band. That was pretty popular for a while because it didn't change the anatomy on anyone. But that's fallen by the wayside because when you think about it, you put in a foreign body, at some point, foreign bodies tend to fail. And then, that means that there's a repeat surgery to go back and retrieve the foreign body. The other surgery that has been around for a long time is the Roux-en-Y gastric bypass. And that's still being done. But nowadays, many people are really preferring the sleeve gastrectomy. And the reason is because, it doesn't alter the anatomy quite as much as the gastric bypass does. When we do a sleeve gastrectomy, we do remove about 80% of the stomach. And we're changing the capacity from about a liter or so down to 60 to 100 milliliters. So it's a pretty drastic drop. And the families need to, or the families and the patients do need to recognize that there will be a significant shift in the way that they eat because they're really not able to take in as much as they were used to eating before. There are fewer complications with this compared to the bypass. That being said, there can still be issues like staple line leaks, stricture formation, bleeding, and then, as I mentioned, micronutrient deficiencies. With vitamin B12, we see that there is decreased intrinsic factor because we have taken out a large part of the gastric fundus. So short-term complications would be those that are within 30 days after surgery. There might be surgical site infections, bleeding, leak, and strictures. There could be pulmonary embolism. There may be risk for readmission or reoperation. One thing that's challenging for many of these patients is that after surgery, it may be difficult for them to be able to drink as much fluid as they need to be able to stay hydrated, just because the stomach is so small. In terms of long-term complications, as I mentioned, nutritional deficiencies, weight regain can be also significant. And so, if you look at the outcomes for the sleeve, there could be as high as 3/4 who actually regain a fair amount of weight afterwards by the 6-year mark. So just because we have the surgery doesn't mean that we are done with our weight loss journey. It's really needed as a tool in the setting of continuing other things like healthy nutrition and physical activity, and then potentially also with the adjunct of medications too. There can be some problems with gallstones or adhesions. There may be issues with hernias, although that's not as much with the sleeve. That one is more with the bypass. There can be issues with reflux and nausea. People may also have problems with bloating, diarrhea, and then dumping syndrome too. With regard to the outcomes, the gastric bypass and the sleeve actually both are very good, and they have fairly similar outcomes. And there was a multi-center study that was done with 177 adolescents who had the bypass, 206 that had the sleeve. And then what they found is that at the 3-year post-op follow-up, there was an average BMI percent loss of about 29% for the bypass, but about 25% for the sleeve. And there was definitely an improvement in the comorbidities. And what we saw was that the sleeve had a much better safety profile. And so you can see here, this is the band. And so there was some weight loss there and change in BMI, but really it's much more significant with the sleeve and with the bypass. With regard to comorbidity remission, what we see is that in the same study, diabetes was better in about 95%, which is phenomenal. So, in working with our diabetes colleagues, we definitely are trying to help our patients that have type 2 diabetes and move them forward on the sleeve, because we can definitely see a significant improvement. There's also remission of abnormal kidney function in about 86%. Pre-diabetes improves in about 3/4. The same with blood pressure. And then with dyslipidemia, about 2/3 get better too. One thing to keep in mind, though, is the sleeve is a lifelong commitment. And the reason I say that is because you really need to take these micronutrients daily. And that is a big challenge for our adolescents. And many of them, they feel so great afterwards. They don't feel sick. And so it's really hard to convince them that you really need to stay on these micronutrients, because we need to be able to make sure that we're not, causing any of these deficiencies. And we do expect that they come in, to get their monitoring for labs to check on this at least once a year. We do it more frequently during the first year, but after that first year, it should be at least annually. There are also concerns about bone health because there is increased risk for osteoporosis after surgery. And then adult guidelines are also recommending these days screening for Barrett's esophagus after surgery and periodically afterwards. So, if we have a sleeve gastrectomy done, then now we're also, bringing on a lot of other maintenance issues, such as lab testing, as well as endoscopy. So in summary, the updated AEP guidelines really advocate for more aggressive treatment of childhood obesity. We have so many new medications now that are available for weight loss, which is really exciting. And bariatric surgery is an option for those that have severe childhood obesity, but it does require a lifelong adherence to the guidelines, including supplementation and testing. And these are my references in case anyone is interested. We have a wonderful team. So in our Watch Clinic, we have Aisha Erkin-Kakmak and Kate Chang. And then on our pediatric surgery team, we have Lon Vu, Dana Morgan, Sarah Haig, and then we have our excellent dietitians, Liz McMillan, Makiko Omori, and Carmen Say. Thanks everyone for your attention today here in person and online. And I'm happy to entertain any questions.
Absolutely. Thank you. With these newer GLP-1 receptor agonists, what is the data related to both pregnancy and breastfeeding?
Let's see. That's a great question. I'll be honest, I haven't really looked at that since I haven't had to worry about that very much with the kids that I've been seeing, but I'm happy to follow up on that.
So Patricia, for the GI side effects, thinking about all these medications that often happen, is there a way of sussing out who's you are predicting who's going to have treatment limiting side effects to help guide your decision making for therapeutics?
I'll repeat the questions just in case for the recording. It might be hard for people to hear from the audience. So the question is about, is there any way to predict who may have GI side effects? Not really. Many people start with the medications and are okay at the low doses. And we definitely see that as they get to higher doses, some people will have problems with GI side effects, but then some will not. But it's difficult to assess who's going to have more issues. I would imagine that those who already have some underlying problems with reflux or abdominal pain might be more prone to developing those symptoms. Yes, well.
Can you give us a sense of what proportion of patients tolerate full doses of those injectable medicines? Like, so when we look at those plots that show that improvement, is that only the patients that were on the gold dose, or do they still get some improvement if they only get halfway up?
So there is definitely, so the question is about, are there still improvements in weight even if people are not on higher doses of medication? So we do see that it can work even at some of the lower doses. And what I have seen too is, some of the patients, when we get up to the full dose and they can't tolerate, if you bring them down to a slightly lower dose, sometimes they can tolerate that better. And then they can still have weight loss with that too. Mhm.
There are a couple of questions on the chat. One is whether you need to take Ozempic for life. Ozempic for life.
So the question is whether or not you would need to take Ozempic or Wegovy for life. So we know that obesity is a chronic condition, and as you saw in some of the graphs, once they stopped giving the medication, the weight went back up again. And I think that we know that obesity is something that is probably going to continue. So most likely this will be a chronic medication as well, depending on how much other support there is, including things like physical activity and nutrition.
You gave in the overview some information about and I'm wondering if you could talk about your take of these various either medication or wondering about about the overall concept because you listed a number of them, but I'm just wondering how is it really something that
So the questions are on uptake of the medications and surgery, as well as the amount of complication of surgery. In terms of uptake, I would say it's quite variable. I have families from many diverse backgrounds and of all different socioeconomic status, and some patients wanted to have the medications and surgery yesterday. Some, I have met with for quite a long time. Some I've worked with for several years, and are absolutely not interested in medications or surgery, even if I feel like it would be a good step for them to consider. So it's really quite variable. In terms of the complications, for the sleeve gastrectomy, what's really nice is that the complication rate is actually pretty low in terms of, I think, long-term types of things. There, readmission, I've definitely seen happen because of issues with hydration, but those are things that can be overcome, and those will resolve over time. So I think there is a small risk for complications, but I think many of those are definitely surmountable. Thank you.
I wonder if you could speak a little bit about the recommendation of screening eating disorder and
So I do like to try to get a sense for how kids are doing with regard to their goals, and then also in terms of their behaviors. So I think it is important to try to do some screening for any eating disorders. And then if I do find that there are some issues, like if it seems like there may be some binge eating tendencies, or if there are any bulimia concerns, then I have definitely reached out to our adolescent medicine colleagues. And so we've definitely managed some patients together. Mhm.
You mentioned that just how bariatric rates complications, which I was surprised as because I have friends with obesity who bariatric surgery as bariatric surgeries, I'm wondering why. Does bariatric surgery have lower rates of complications than, do you happen to know if bariatric surgery has lower rates of complications than other surgeries on people with obesity, and if so, how?
In terms of, so question is about the rates of complication of bariatric surgery with consideration that patients may be denied other surgeries for other reasons because of concerns about weight. I think that with bariatric surgery, you know, it's a laparoscopic procedure, so it's actually a relatively short procedure. It can be done in about an hour or so, and they are taking the stapler and just cutting through the fundus. So the procedure itself is not very involved, so to speak, compared to say like the bypass. The bypass is definitely more fraught with complications. When we do our screening for bariatric surgery, it is actually a fairly comprehensive evaluation. So those who get to bariatric surgery, we have done a lot of workup, including cardiovascular evaluation. Many have gotten an EKG and chest X-ray, and then potentially an echo as well. We have checked for OSA. They've had a sleep study, and then they've also had evaluation by a mental health professional to assure that there's assent for the procedure and understanding of what the procedure entails. So it may be that also there's some careful selection of who is a good candidate for bariatric surgery. And so, all of those things are being taken into account with regard to, making sure that we have the right candidates. Does that answer your question?
The GLP-1 agonists, have any issues with shortages? And for your patients that are on it, you ever have to discontinue that?
So the question is about, are there issues with the shortages? And have we had to discontinue medications because of shortages with the GLP-1 agonists? The answer is yes. That is definitely a challenge. With the liraglutide, that one has been easier to get compared to the semaglutide. And so because of that, we have many patients who have been using liraglutide instead. And so that's where I'm hopeful that as tirzepatide becomes more available for the adult population, that hopefully will free up some of the supply of the semaglutide, for our patients who are not eligible yet.
A couple more questions on Zoom. One is about what is the youngest age that you would do medication/surgery? When is the first time you actually start saying you got to address weight?
So the question is, what is the youngest age that we would consider for medications or for surgery? So for the surgeries, that one at this point, actually, the guidelines, they are not specific in terms of a youngest age from the surgical guidelines. According to the AAP guidelines, the youngest that we should start to refer and consider would be at 13. And so, we could start to have some discussion, but, many times we haven't, in our program, we haven't gone that low yet, for those that are, less than 13. And so I think that, over time, it might be that we become more comfortable with these younger age groups, but right now, as our program, we haven't gone that low yet. But, 13 and up, we could consider doing. And then as far as medications, so the guidelines do talk about having people at least be considered for medications starting at age 12. And that's where, the medications have their FDA approvals at age 12 for many of them. That being said, I do use these medications in clinic, off-label at younger ages too. The thing with certain medications is that we may not be able to get insurance approval for some of them. So, for example, for the GLP-1 agonist, it's challenging to get them even for those where it is already indicated from an age standpoint. And I think for those who are younger, it is very difficult. But things like topiramate or stimulants, those are already approved as indications for younger children, and so those are easier to get covered.
And another question asked, how long does it take after sustained weight loss for the body to get used to it? In other words, when the leptin and ghrelin levels sort of reach a new steady state?
Mm-hmm. That's a great question. So the question is, when or how long does it take for the body to reset its hormonal levels after taking medications or working on weight loss? Uh, Unfortunately, the body has a very stubborn variostat. And once the body gets up to a certain weight or a certain BMI, it really does not want to come down. And all of the registry studies that have been done to take a look at this have found that it is years after surgery or significant weight loss that the body starts to reset in terms of trying to say, I'm okay at this weight. And so, that persistent hunger may be there for several years afterwards. And so I think that's where the guidelines to be more aggressive and to treat earlier are actually really important, because we have many kids who at the age of, say, 10, are already at the weight that they're supposed to be as adults. And so if we watch and wait, there's no way that we're even going to try to get them back down to what would be considered a healthy BMI. And so when you think about things like bariatric surgery, for example, with the sleeve, the amount of weight loss that you might expect would be potentially 50 to 90 pounds or so. And so if you're already coming with a weight of 300 or 400 pounds, and we're only aiming for max 90 pounds or 100, we're getting you from 400 to 300, right? We're not getting you down to 150 or 200. And so that's why it's important to try to tackle this earlier so that we don't get to the point of no return.
And I have a question that's almost maybe more of a philosophical question, but I'm sure you're thinking about this, is in our society, there's been a call to be more accepting for people who are overweight and obese. And we now, like Lizzo, enormously popular among particularly young people, that also create that acceptance, which I know from friends who have struggled with weight loss is very freeing to have that movement in society. But at the same time, we, from a medical perspective, know that there's all these long-term complications associated with obesity. How do you balance those two things? Like encourage people to participate in weight loss programs and at the same time provide a sense of acceptance for who they are and what their bodies look like.
Thank you for that question. So the question is, how do we balance between having a recognition that elevated BMI, is associated with multiple chronic medical conditions, with the fact that as a society we also want to be non-stigmatizing and want to promote healthy body image, and that's definitely a challenge. For sure. And I think that we as a medical community do have a responsibility to try to promote, people first language and to promote the idea of making sure that we are trying to promote health and to try to avoid, causing stigma, and also to try to help our patients with any stigma or bullying or any adverse consequences that they may be experiencing because of having elevated BMI. We definitely see that a lot in especially our adolescents, right? I would say that probably the common refrain that comes up when I'm talking to a lot of our teenagers about bariatric surgery is that they want to be able to go to school and not be picked on or have any issues with bullying. And for those that have worked on surgery and have had weight loss, they all uniformly tell me that it has been just life changing because they feel like they are able to now engage in society in a way that they weren't able to before, and that they are able to make more connections with people, to be able to not feel like their weight is a hindrance to any activities that they may be interested in participating in that they felt like they couldn't participate in before, whether it be PE or getting on a roller coaster or sitting in the chair at the desk at school, right? All these things that are really tough, on our teenage population. But I think in terms of clinic, we definitely try to promote that we are wanting to help them with health, and to me that's the most important thing. And I want to try to make sure that we don't get too wrapped up in the numbers as well. Mm-hmm.